So how do we know when it's time to come see you?
Well, I think if these symptoms resonate with you and and you have changes in your activities of daily living, your calves hurt, so you put your legs up and it interrupts your dinner. It disrupts your work patterns. It makes it so you're not exercising because your legs are gassed at the end of your workday. I had a school teacher tell me exactly that. She'd get home from her school day and her feet needed to go up because her legs were so exhausted. Well, she can't exercise, or she doesn't feel like it. So my point is, if those things are, if they're affecting your activities of daily living, then it's a very reasonable consultation. The other thing is, people can have some scary things happen with veins. They can spontaneously bleed. An innocuous little shaving cut won't quit, and so forth. The main first aid if that happens to you is to elevate and to put focal compression down. These veins can clot, so people can go along kind of nursing their ropey veins, which are pooling blood, but that blood is stagnant and it's prone to clotting. So something that is just kind of pooling and they think it's just kind of a bother that they work around suddenly becomes a really uncomfortable event that lasts for several weeks, where they've basically had a traffic jam in the veins and the venous blood has congealed there and caused clotting. This isn't dangerous in the way that a deep circuit clot is, but it's certainly something that I see when people finally have long-term vein issues come to their attention. But I think skin integrity issues. So changes in the skin, your ankles are starting to be swollen and brown. You have a wound that won't heal lower. Now, a lot of doctors are aware of the influences of venous insufficiency, which is what we're talking about, the bad valves, of pooling venous blood on limiting wound care. But not everyone is, and patients will sometimes nurse wounds for long periods and they're not healing well, and it's not an arterial, as in oxygen or glucose delivery problem. It's a venous insufficiency problem because those exhausts that we talked about, carbon dioxide, lactate, and urea, are just congesting in that tissue that's trying to heal with building blocks.
So when we come see you, what are some of the treatment options available?
So when you come and see me, I need to be cautious about attributing your symptoms to any vein problem. So the first thing I need to do is bring my experience to bear, really listen to your symptoms and try to discern whether it would make sense that this is a venous problem. Then, if I believe that there's some reasonable risk of that, the most important pivotal test is actually an ultrasound exam. And it's not just your generic ultrasound that shows that you don't have a deep clot. It's actually a study, and I think it ought to be done by somebody who's pretty versed in venous ultrasound studies, which determines the function of the valves in terms of their competence. It also speaks to the anatomy of the veins. Who's pooling? Who's talking back to whom? Where are they going? It also speaks to the adequacy of your deep system. Is it open? Is it competent? Does it have any influence on your symptoms? So those are the three main portions of a good ultrasound exam. Now, with those two pieces in mind, a careful history, a good physical exam by your doctor, and then a competent and thorough venous insufficiency study with ultrasound, now I'm able to speak to the likelihood of your veins being an issue for the symptoms that you bring me.
So if we meet all those criteria, what types of treatments do you use to fix the
So
problem?
the treatments come in basically.
Let's crop that real quick. DSLR, it has a recording limit of about 10 minutes. So I'd rather crop it now.
Mm-hmm.
I'd rather crop it now than have you be in the middle of an answer and then have it.
Okay, you want to cut the camera there, James?
I'm assuming that we're editing.
So I'm in your office. I have vein problems. What do you tell me?
Well, I've diagnosed your vein issues with an ultrasound, and I've combined them with what I've learned from you from your history. I always offer patients options. I think it's important to understand there are conservative measures, which we talked about. Conscientious use of compression stockings, elevation, frequent activity. In the case of mild discomfort, mild analgesics like Tylenol or ibuprofen. That said, the other alternatives are treatment. So I kind of make the comparison that if you had a tire that leaked, you can fill it up every day, which is what those conservative measures do, or you can get your tire fixed, and that's what my interventions would do. So to the extent that veins, their issues are often secondary to the failure of the valves, And there's a lot of redundancy in the venous circulation. What I mean by that is there's a lot of roads back to the heart. So what we can do with those incompetent veins is remove them from the circuit. And how do we remove them? Well, we remove their function without taking the vein out by using a heated catheter, where with local anesthetic, I can introduce a catheter into what is called the truncal vein. I like to think of it like a tree trunk. It's responsible for all the branches.
Right.
So with the truncal vein, I'll introduce a catheter into the vein, surround the vein and catheter with lots of local anesthetic. All the while the patient's awake and we're visiting about their children and their history and my history, etc. But in a very kind of a patient, essentially about an hour treatment, I'm able to enter that vein, introduce a catheter into it, and heat the vein in a way that it is closed, so it no longer carries the blood up, but it doesn't allow it to pool. And then for the larger branches, sometimes I'll use some very puncture-like incisions and pull those up. And the reason I like to do that, that's called microphlebectomy. Don't confuse that with vein stripping. Vein stripping was an elaborate...
That's scary.
It was scary.
Yeah.
So in vein stripping, we introduced an instrument called the stripper into the vein, and instead of closing it with heat, we'd actually introduce an instrument into it called a stripper with a big cap on the top that then I would pull, or a surgeon would pull like he was starting a lawnmower, and tear the vein trunk out.
That just does not sound good.
Very brutal procedure, and the answer to that has been the heated catheter. So I'll do what vein stripping used to do with the heat, and then with a combination of injection sclerotherapy, where I inject chemical agents into the veins, and sometimes mechanical excision of vein segments called microphlebectomy, micro because they're tiny punctures, and phlebectomy because they're excision of a vein. I'm able to eradicate the things that are growing off that feeding trunk.
All right, so can you describe that difference again between sclerotherapy and then also the heated catheter?
So the heated catheter uses heat in a controlled way to close a vein in a reliable way, so it no longer allows the blood to pool. And then where I inject a chemical into the vein, those are for more like spider veins in the skin, or smallish, those blue veins people get that are kind of small but nuisance veins. They're too small to excise, but they're big enough to bother a patient, and those I'll inject. One of the key discriminators there is most of this care, the diagnosis, the ultrasound, the closure of veins, phlebectomies, most of that is covered by insurance with the exception of three things: co-pays, deductibles, and co-insurance. I like to remind patients there are out-of-pocket expenses even though you're insured. But if we get appropriate authorization, we can manage most of the venous issues. To the extent you're trying to gloss and pretty up at the end with some of the finer veins, that's where I'll use sclerotherapy.
All right, and so what about the big bulging veins that we often see on our calves or even on our thighs? What is the treatment that we do for that?
Again, appropriate diagnosis, so I find the trunk, and typically in one procedure, though sometimes I break it out, close the feeding trunk, and then where it's pooled and become visible out by the skin, I'll make little punctures over those and tease some of those chunks up so they're not there to visibly bother the patient afterwards. There are two things about those that people ought to know. If I just close the trunk to them, if there's enough blood flow after that closure to keep them open, why then I'm not a very good specialist, am I? Because they still got their ropey veins. But if there's not enough blood flow through those veins, now they clot and are firm and hard and take months to resolve. So for the sake of a few minutes and a little extra local anesthetic, I can often, and like I mentioned, for big bulky veins, I might break it into a separate procedure, but I can often take care of those pretty quickly in conjunction with a closure procedure.